We just finished about and spreading odontogenic infection with severe or systemic features. And next, the type of pains. This table 12 is still continuing, which is a dental pain worsening 1 to 4 days after the tooth extraction. So here we have alveolar osteitis or dry socket. The pain worsens after a day or 2 or 3, up till 4 days it can happen. So extraction was done on Monday and there is a severe throbbing kind of a pain by after extraction. So typical history of extraction would be there. Again, initial management, if by medical practitioners, flush the socket with warm sterile saline until all debris is removed from the socket. Offer analgesics. NSAIDs are preferred if the patient can use them. Advise the patient to see the practitioner who performed the extraction urgently, and antibiotic therapy here is not indicated. Very clearly, alveolar osteitis is just the inflammation of the socket. The clot is not able to retain in that place. It has got dislodged. We do not need antibiotic therapy for this because it's not an infection. So just dental treatment, what would be needed would be irrigation of the socket, analgesia would be needed maybe, and obtundant dressing may relieve the pain. So, eugenol packs give relief to the patient. This is dry socket. Then there is another thing called as dental infection post-extraction. What would be the difference between dental infection post-extraction versus alveolar osteitis? Infection would be having swelling alongside. It would be having, maybe pus draining through, or maybe having, trismus, inability to open mouth completely, or things like fever, tachycardia. So it is infected. There you would prescribe antibiotics. So simple, plain rule is check for the patient's body temperature, axillary temperature, which would give an idea of dry socket versus infection. Most common finding is alveolar osteitis. The prevalence-wise, infection is less of a chance. Then acute onset of severe pain throughout the mouth associated with gingival bleeding and necrosis or ulcers of interdental papillae. So this would usually be called as the punched out ulcers. Severe sore mouth, gingival bleeding, halitosis is usually present, and these ulcers are producing white slough. This is called as a necrotizing gingivitis because here the gingiva is dying. It is getting necrosed. It is producing that whitish slough. Initial management by practitioners, offer analgesics. To select an appropriate analgesic, we would read about the analgesic regimen soon. So here analgesics is prescribed. Chlorhexidine mouthwash or hydrogen peroxide mouthwash may be used if the pain limits the patient's ability to mechanically clean their teeth. Advise the patient to see a dentist urgently. For further management, we would see previously we have already covered it. Dental treatment, thorough local debridement of the gingiva, local irrigation, antibiotic therapy are needed. It is an infection. When we talk about necrotizing gingivitis, it is by anaerobic microorganisms. So treat it with antibiotic. Metronidazole would be needed in here. Then we have acute unilateral or bilateral pre-auricular pain. Mouth opening may be restricted. So pre-auricular is always the TMJ joint. Temporomandibular disorders are the likely cause. Advise the patient by medical practitioners, what they will do. Advise the patient to take rest, to rest the jaw, eat only soft foods, avoid extreme jaw movements, example, yawning. Advise the patient to apply cold or warm compress as indicated. Offer analgesics. NSAIDs are preferred if the patient can use them. Advise the patient to see a dentist as soon as possible. For further management advice, we would see further. And then dental treatment. If conservative measures fail, referral to oral medicine specialist or oral and maxillofacial surgeon may be required. This is dentist role is limited, but still the medical practitioner would refer to dentist. And and what would dentist do? Give conservative measures, okay, and then refer to oral medicine specialist or oral and maxillofacial surgeon. As a dentist, you would also do the similar things which this medical practitioner did. Nothing much greater you can do. Then we have dental pain that worsens when the head is tilted forward. So forward bending pain or stepping down pain, which happens in the maxillary teeth more. The pain which is happening on the jumping exercises when the patient says, I'm going jogging and my teeth hurts, it is by maxillary sinusitis. Why so? Because the fluid is collected in the maxillary sinus. When the patient, makes the movement head tilt forward, that fluid accumulates in front. There is a collection together of that fluid. It carries through the pain sensation through the maxillary nerve, and patient feels that the teeth are hurting. So that is how the pathophysiology of maxillary sinusitis is. Initial management by medical practitioners, symptomatic therapy is recommended and antibiotics are rarely needed. Dental treatment here is not required. So again, it is something similar to trigeminal neuralgia case. It is not required. I will share another example of a case where we need to identify which is the treatment needed and then proceed for the dental treatment. What is the tooth condition? Achieving the proper diagnosis, then proceeding for pain relief. So it happened with my cousin that he was having a toothache and he visited dentist back in India. It is the story of there. So dentist had already, the same dentist some time back, say 5-6 months back, did RCT on his 4-6. But suddenly he still has throbbing kind of a pain and it's still going, gnawing pain and going on. And suddenly he has a very excruciating pain one night and not able to sleep because of this pain. So he shares with me this ordeal that he already has got the root canal treatment and he's still having the pain. So I thought maybe there is a missed canal, maybe there is a left out nerve tissue or something. So I asked him, does he have an X-ray for that tooth? He said no. Then he visited the dentist again. And dentist told that RCT and everything is perfect. It's fine. Nothing to worry about. What he needs is extraction of his 4-8. So the painful tooth is, which is yet not erupted or partially erupted or something, that is causing him the pain. And which didn't, I couldn't make much sense of it because of the pain symptoms and the pericoronitis if it is. So I asked my aunt to take picture of his mouth and still send me. But again, the symptoms of the pain and variant of like what he was describing, the pain type and what treatment suggested that it is 4-8 pain, it didn't make sense. So what I asked him was get an X-ray done from another dentist. I referred him to another dentist. And then the 4-6 was, one of the canal was unfilled. There was a big radiolucency in one of his root, maybe distal root, as far as I don't remember it correctly. So it was re-RCT and it was such a throbbing pain he was having. But because wrong diagnosis, failed RCT, and they were about to, do extraction of 4-8, again call an oral surgeon, make him pay for impacted ate extraction, and again his infection would have still prevailed. He would have maybe visited another dentist if he had got this 8 impacted extraction also done, because problem was actually with 4-6. So again, so that is the potential harm of not doing diagnostics well, not identifying the source of pain well, and proceeding for treatment. Now you should be able to correlate what symptoms lead to what kind of pain. And this table was majorly a guide for that. We go back to this area. That patients with dental pain presenting to a medical practitioner, if a patient with dental pain presents to a medical practitioner and is unable to see a dentist promptly, interim treatment may be needed. We would see, like we had seen in the table, for initial management of common causes of the dental pain. However, the medical practitioner should stress the importance of seeing a dentist, because dental treatment is often the definitive treatment of conditions causing dental pain. If dental review is not immediately available, the medical practitioner may consider a panoramic X-ray, a OPG, to exclude serious pathologies, example, gross dental caries, jaw fractures, jaw lesions, such as cysts. Indications for analgesics of acute dental pain. Now, analgesics do help. They do modify the sensation of pain, but do not address its cause. They are somewhere acting on the pathway. Wherever inflammation is happening, they are dampening it. Okay. So, but they are not treating the cause as such. Therefore, acute dental pain, analgesics should only be used as an adjunct to dental treatment in the following circumstances. When the patient's pain cannot be eliminated or adequately controlled by dental treatment and other required drugs, example, antibiotic therapy for spreading infection. Following surgical procedures that cause post-operative pain. And when a patient has presented to a medical practitioner and is unable to see a dentist promptly. Interim analgesics should be offered for certain conditions, and the patient should be reminded that dental treatment is necessary to treat the cause of the pain. So we have this conditions where it is only used as an adjunct. Again, they are stressing on in the box as adjunct to appropriate dental treatment. For analgesic regimens in this topic are only suitable for nociceptive pain. For neuropathic or nociplastic pain, further investigations and management approaches are required. So all the conditions which we read in this table are actually nociceptive pain, right? Other investigations like for TMJ disorders and deeper tissue pains, neuropathic or further on would be needed. We have to refer to oral medicine specialist. Then we have choice of analgesic for acute dental pain. So when choosing an analgesic regimen for acute nociceptive dental pain, consider the severity of the patient's pain and patient factors that may influence analgesic choice. The factors that influence the choice of analgesic for acute dental pain is the pain mild, moderate, or severe. That means what is the experience of the pain by the patient. Pain severity determines the most suitable analgesic regimen. So sometimes we ask the patient in 1 to 10, how much would you rate the pain? So mild, moderate, severe, to get it more scaled objectively. But still, can we be very objective with it? It's no, because patient experience is measured. Here it cannot be quantified. When assessing pain severity, consider both patient-reported pain severity and expected pain severity based on cause of the pain. So we know for a fact that irreversible pulpitis pain is quite severe of a pain. So patient would be having that throbbing pain, scintillating kind of a pain with irreversible pulpitis. Whereas the pain of reversible pulpitis would be like mild, coming, going, and pain of fracture tooth would be biting pain. So this is mild, moderate, severe based on expressed pain severity and the expected pain severity. Consider potential adverse effects and contraindications or precautions to analgesic use. These factors may influence analgesic choice. And then we have, can the patient take medications orally? Oral administration is preferred. If this is not possible, if the patient has difficulty swallowing or it's a spreading infection with trismus happening, with breathing compromised, airway compromised, then we would go for IV therapy. Okay, difficulty swallowing or GIT absorption also is likely to be significantly reduced. Consider suppositories or injections. Then, although NSAIDs are preferred for acute nociceptive dental pain because they are anti-inflammatory, their adverse effect profile limits to their use in some patients. So, what would be the patients which will not have, cannot be given NSAIDs, or not very safe to be given NSAIDs is a better way to say that. Before prescribing an NSAID for a patient, determine whether NSAID use is appropriate based on their comorbidities and risk factors. If NSAID use is appropriate, ibuprofen is preferred because of good efficacy with limited toxicity. So wonder drug for dentists for dental pain to be given to patients is ibuprofen because it has good efficacy, limited toxicity, and widespread experience we have with its use. However, other NSAIDs have different safety profiles and may be preferred in some patients. That we have done a lot in the previous analgesics part, the pharmacology part in this TG. Paracetamol can be combined with an NSAID or used alone in patients who cannot take NSAIDs. Okay. If very severe pain, we can combine paracetamol with NSAID, or in patients who cannot take NSAIDs. Opioids can be used for acute nociceptive dental pain in adults when non-opioid analgesics and non-pharmacological measures, example, dental treatment, have failed to provide adequate pain relief or are unlikely to do so, example, severe pain. And oxycodone is preferred, do not use codeine. Whenever for dental use we are giving opioid, it is oxycodone. Again, we have read this in analgesics part. Then combining analgesics from different classes can result in enhanced pain management, synergistic analgesia. Example, eliminating ibuprofen and paracetamol provides, combining ibuprofen and paracetamol provides greater pain relief than either drug alone. So one blocks the peripheral pathway, NSAIDs are working on the peripheral pain pathways, whereas paracetamol is more on the central pain pathway. The opioids are again on the central pain pathway. Then analgesic regimens for mild to moderate acute dental pain in adults. For factors that affect the choice of analgesic regimen, non-opioid analgesics, NSAIDs, and paracetamol should be taken regularly rather than as required to achieve continuous pain relief. So SOS is not an effective way to prescribe the analgesic. For if adjunctive analgesia is required for mild to moderate acute nociceptive dental pain, prescribe ibuprofen 400 milligram orally, 6 to 8 hourly for the shortest duration possible, no more than 5 days without review. So if the patient maximum can take without other review 5 days of ibuprofen 400 milligram thrice a day. Okay, 6 to 8 hourly is approximately thrice a day. Plus paracetamol 1000 milligram orally, 4 to 6 or hourly. So here it becomes 4 times a day. Okay, to a maximum of 4 gram. We cannot give more than 4 gram of paracetamol to a patient in 24 hours for the shortest duration possible. Again, it should not be patient is when you are prescribing, the number of days should be limited. Avoid fixed dose combination products because they do not allow the daily dose of each drug to be maximized. As the tissue heals, stop ibuprofen and use paracetamol as a single drug. So the better is after the healing has been established or it is establishing, ibuprofen should be stopped, only paracetamol should be given. If patient has some risk factors and we want to use selective COX-2 NSAID, then the preferred choice would be celecoxib, 100 milligram orally, twice a day for shortest duration possible, no more than 5 days without review, plus paracetamol 1000 milligram orally, 4 to 6 hourly to a maximum of 4 gram in 24 hours for the shortest duration possible. As the tissue heals, stop celecoxib and use paracetamol as a single drug. If NSAIDs are contraindicated, use paracetamol 1000 milligram orally. Only paracetamol here are using. Okay, if it is a contraindication to use NSAIDs. 4 to 6 hourly for shortest duration possible. If analgesics are used after a surgical procedure that causes post-operative pain, inform the patient of usual course of pain. Example, pain is worst 48 to 72 hours after surgery, then improves. So we have to pre-inform the patient that the post-operative pain would increase after today's impaction surgery. For example, it would get worse after 2 days. So you might have less pain today and tomorrow. You might have more pain after 2 days to 3 days, because that's how the inflammatory mediators are rising if they are going in that curve. So pain would be worse gradually after 2 to 3 days, and then it will slumber down. So this would keep the patient's confidence on you as a dentist, because you have already guided them that this is coming through. Advise the patient to return to the dentist for review if pain persists. This was mild to moderate pain. Then we have analgesic regimens for severe acute dental pain in adults. For factors that affect choice of analgesic regimen, we had seen before in the analgesics part. Now, non-opioid analgesics, NSAID and paracetamol should be taken regularly, not discontinuous, not as required. For severe nociceptive pain, we have combination. It is example after dental surgery. Ibuprofen 400 milligram remains the same dosage, or celecoxib, either of it, whatever we want to choose. Plus we would give paracetamol, same dosage. Plus we would give oxycodone. So here we are adding centrally acting analgesic, which is our opioid. Immediate release 5 milligram orally every 4 to 6 hours as necessary for the shortest duration possible and no more than 3 days. Use a lower dose in elderly or frail patients because they are particularly vulnerable to its adverse effects. Prescribe small quantities to avoid inappropriate use in the community. In patients who cannot use NSAIDs, use paracetamol plus oxycodone. Always consider the benefits, harms, and regulatory requirements of prescribing an opioid. Prescribe lowest effective dose and advise patients to take a dose only when necessary. So they should not be using opioids as, as and when they find necessary. And ensure the patient understands the intended duration of the opioid use and when to stop taking the opioid or return for review. Example, if pain persists for longer than expected. This is of particular importance because long-term opioid use often starts with the use of opioids to treat acute pain. So patient gets habitual, addicted to, they are the drugs of dependence, okay? As the tissue heals and the patient requires less analgesia, use a stepwise approach to tapering and stopping analgesics. First, it would be in the reverse order. The last which was added would be removed first. Oxycodone is the first to be removed. Then stop ibuprofen, then or celecoxib, and the lastly stop paracetamol. The safest one can be continued for long. Ensure that your patients understand intended duration of opioid use for not having toxicity, dependency, and other side effects. For patients currently taking opioids for another indication, suppose a patient is already taking opioid for backache, consult their medical practitioner to determine an appropriate analgesic regimen. Specialist pain management advice may be required if patient is opioid dependent. So usually these patients can come to a dentist that give me a opioid drug. That is the drug which suits me. I am having this toothache, prescribe me. My doctor, my previous dentist always prescribed me this drug. So we are always on lookout for, delineating between whether this patient actually needs opioid for the dental treatment. Usually for irreversible pulpitis, reversible pulpitis, periapical abscess, the analgesic of choice to be used as an adjunct is always our NSAID. So rule out whether they are opioid dependents and approaching your dental clinic just for you to prescribe them this drug. If opioids have not been required in hospital or pain can be successfully managed with non-opioid analgesia, do not prescribe opioids on discharge. Do not use modified release opioids for acute dental pain. So modified release opioids means opioid patches. Okay, fentanyl patches are available, which give slow delivery of. See, basically these patients are dependent or addicted to opioids because of the previous use, and do not ever, for dentistry, we do not need them. And dentistry, the work is controlling the inflammation, which is best controlled with NSAIDs. It cannot be best controlled with opioid per se. Administering LA by infiltration or lesional block is an alternative or additional strategy for the management of severe acute dental pain, provided the clinician is competent in these methods. For example, the patient says that I'm traveling, I have severe pain, I don't have time, I'm traveling, and I'll take appointment for RCT from another clinic. So it is better to administer LA to this patient and than prescribe him opioid if it is in a very severe pain, and just give instructions of post anesthetic that it will be numb, do not bite on the lip, cheek, or anything. If analgesics are used after a surgical procedure that causes post-operative pain, inform the patient of the usual course of pain, again the fact that it worsens in 48 to 72 hours after surgery and then improves. Advise the patient to return to the dentist for review if pain persists. If post-operative pain is longer than expected, ask them to return. Then we have children regimens. This is the tables for children. We will cover children's analgesic regimens today. We have, for factors that affect the choice of analgesic regimen, do not use aspirin in people younger than 16 years because of the risk of Rey syndrome, a very important area to memorize, that for analgesics younger than 16 years, we are not prescribing aspirin because of risk of Rey syndrome. Do not use opioids for acute dental pain in children outside the specialist setting. So you have to refer a child for acute dental pain to the pediatric dentist if pain management is needed, which is beyond your scope of giving the basic NSAIDs. For acute dental pain in children 3 months or older, use ibuprofen or paracetamol. Ibuprofen and paracetamol can be combined for the pain management. Give doses regularly rather than as required. And to achieve continuous pain relief, use ibuprofen. Here we have 5 to 10 milligram per kg, up to 400 milligram orally 3 times daily at 6 to 8 hour intervals. So for a child, we are measuring it 5 to 10 milligram per kg of their body weight. 10 kg child, 50 milligram we would get, 50 to 100 milligram like that. Paracetamol also 15 milligram per kg, up to 1000 milligram orally. Their maximum dosage is their dosage for a adult patient, which we give at once. Okay, so this is 15 milligram per kg. You remember this 5 to 10, and they have done the work easier by calculating the dosages and giving it in the table for you to quickly refer when a child patient is at your clinic. But they are not expecting you to memorize this. Then we have something called as we would be having a knowledge of particular care is required for dose selection in children at extremes of weight or height. For children who are not obese, calculate the dose of analgesic using the child's actual body weight, even if they are significantly underweight. So if the child's weight cannot be determined, use the age-based table. 13 and 14 for paracetamol, like ibuprofen and paracetamol. Age-based tables also they have given, but usually we would have weight-based calculations. However, when they have mentioned about the age tables, they also say age-based dosing is imprecise for children at extremes of weight or height. So a patient may be having an age of 12-year-old, but a height of a 18-year-old, already mature adult. So age-based dosing is imprecise for them. Then for children who are obese, calculate the dose using ideal body weight. Because of changes in the drug pharmacokinetics in obesity, using the child's actual body weight will result in excessive dose. So imagine a 60 kg child, okay, a 10-year-old child which is who is obese would be having a weight of maybe an adult 60 or 70 kg, or we have these obese children. So if we prescribe them the weight-based drug, it would be too much of a heavy medicine based on, because their pharmacokinetics, the absorption, distribution, metabolism, and excretion of drugs is not as that of an adult. The liver system, the kidney system is not that developed as of an adult. So here, if the child's height is known, estimate their ideal body weight using the corresponding weight for the height percentile on the growth chart. So we take their ideal body weight. For a 12 kg, this much of a height, this much should be the weight. And we calculate the dosing as per that. If child's height cannot be determined, use then age-based dose. Okay, so for ibuprofen, table 13 and 14. So getting it. For normal children, we are using age-based approach. For children who are and we are using the actual body weight for that calculations. But for children who are not obese and significantly underweight or anything, if the child's weight cannot be determined for some reasons, we would use age-based approach. But for children who are obese, we cannot use their direct actual body weight. We calculate their ideal body weight based on their height and age. If we are not getting their ideal body weight, even if height cannot be used, then we only use age based. So these are how we decide the dosing of for these children. This is how the tables look like. Weight-based dose and appropriate volumes of ibuprofen liquid for children. Age, average body weight, dose of ibuprofen, volume, approximate, which is 100 milligram per ml liquid. If it is available in syrups is available 100 milligram 5 ml, how much would be the volume needed, and 200 milligram per 5 ml liquid, how much would be the volume needed. And then we have this weight-based dose and appropriate volume of the paracetamol likewise. So this was ibuprofen, paracetamol, and that's about the pain management and the for our patients at a dental clinic. Do you have any doubts?